All right, good evening, everyone. Welcome to the MyCP webinar series, where we do a number of community-focused presentations about research that is going on in the Cerebral Palsy Research Network. My name is Paul Gross. I have with me Dr. Bhooma Aravamuthan, who goes by Dr. Buma, which is what I'm going to stick with. And tonight she's going to be talking to us about her research into community attitudes towards cerebral palsy diagnoses. As always, I'm going to start with just a couple points. I see I didn't update my agenda slide anyway, about the Cerebral Palsy Research Network and MyCP. So the network was formed to have a mission to improve outcomes that people with cerebral palsy value most, and I'll come back to that underlying statement in a moment, through high quality clinical research and quality improvement initiatives. And I say that people with cerebral palsy value most because in 2017, we ran almost a 6-month-long process to bring the community together, both people in the community with CP, caregivers for people with CP, advocates, and then clinicians, researchers, and worked on a patient-centered research agenda. So everybody we generated from whole cloth a patient-centered research agenda. And then we came together in Chicago and we sort of prioritized things and clarified things. And so that is at the center of what CPRN does. So it's a little bit conceptual, the network. What it really is it's a collaborative effort of a number of institutions and clinician science in those institutions, therapists, researchers, patient advocates, all working together to conduct this research to improve outcomes for people with CP. Physically, we have a data coordinating center, i.e. a place where the data comes in and stays to stay secure at the University of Utah in the Department of Population Health Sciences. We build a bit of infrastructure to sort of accelerate and improve research and to follow long-term outcomes. There are 2 registries. There's a clinical registry, i.e. it is data that is collected in the electronic medical record while you're seeing a clinician at a hospital. And that clinical registry, which is just a database, characterizes patient characteristics, interventions, and outcomes. And then that gets moved to the University of Utah and gets combined into a big registry. So we have kind of a big data project. And then there's a community registry, which is hosted in MyCP, which I'll talk about in a moment. And that's really intended to get at information that we can't get at by talking to you in a clinical setting, because either there's not enough time or it's just not necessarily the area or expertise of the clinician you're seeing about cerebral palsy. And so that allows us to follow both children and adults long-term. MyCP, or My Cerebral Palsy, is basically a web portal. It's a place where we give news about CPRN's research, but we're also creating a way in which people from the community can participate in research, both by participating in that community registry through surveys, but also through discussions about research. So as an example, if you have a question for Dr. Buma that you don't get to tonight, you can actually go to that and post it, and she'll see that question there. So it allows us to have this ongoing discussion with the community about your lived experience and about research, about priorities, and get a chance to get engaged, not only in being like a subject of research, but what's important to do here? Do you want to get involved in the co-production of research? So it's a great opportunity to be engaged in research. And then we're also working on a series of tools to enhance your experience in interfacing with clinicians if you have CP. There's just one of those tools is built into it so far. Anybody can sign up at mycp.org, and I would encourage people to do that if you haven't done that. We exist to accelerate research in these areas that people with CP value most highly. This is our research pipeline as it looks today. So at the left end, we have where concepts are generated, and then they get reviewed by our large investigator committee, all the clinicians that are at the various 28 sites of CPRN. They go through a process of getting approved, look for funding opportunities, getting implemented as a study, And then when the study results are available, written up as a manuscript, published, and then we take that evidence and try to roll it back into the beginning of the clinical treatment cycle. So we're always implementing the best practices. The three studies here that are have a little gray line around them are three that Dr. Buma is involved in. As I was creating this, and I always circle the study that someone's leading, and I was like, wow, she's really doing a lot in CPRN. So a number of you may have participated in the Research CP Dystonia edition, and we're just getting to the writing phase for that. She's going to talk about this study that's in process right now. And she's also co-leading this effort to improve dystonia diagnosis, which if people have questions about, they can about in the Q&A period. So CPRN is located across North America. The green pins are places where we have sites that are actually enrolling people in the registry today. So you see we have a good breadth, good spread across the United States. The yellow pins are sites that are still working on preparing the registry because it's not a small bit of work technologically. The red sites are working through getting their approvals in place. We have to get data transfer agreements in place and what are called IRB protocols to protect human subjects. And then the blue ones are sites that have expressed an interest and they're starting the process so that they can get onboarded. And so Duke just raised their hand, and that's the second one here that's in North Carolina. And then also Mayo Clinic raised their hand just in the past week, and New Mexico is planning on, University of New Mexico is planning on joining. So it's forever growing. It's an exciting amount of work going on in CPRN. But the main topic of tonight is to hear from Dr. Buma, who is an MD, Doctor of Philosophy. So you very often hear MD, PhD, but this is a function of getting your doctorate in at Oxford. And she is an assistant professor at the Washington University School of Medicine, and her focus is on pediatric neurology. And she's a movement disorder specialist. And that she's really trying to move the field forward and getting more and more of these types of clinicians involved in cerebral palsy. Part of where she's doing that is she's very involved in the American Academy of Neurology, and she is a vice chair of the Adult Intellectual and Developmental Disability section. I assume that's still current, Buma, and recently has joined the American Academy of Neurology's Child Neurology Quality Measures Standing Working Group. And as I said, she's the leader of 3 studies. So with that introduction, I am going to turn it over to Dr. Buma. Let me stop sharing my screen so she can take over.
Okay, can everybody see my screen?
Yes.
Perfect. Okay, thank you for that wonderful introduction, Paul. It's been a joy to work with CPRN, and I'm very grateful that CPRN has facilitated this preliminary data that I'll be sharing with you, which is family views on cerebral palsy diagnosis. So cerebral palsy has been defined multiple times over the years. And even though there have been multiple definitions published and revised, they largely concur with this definition from 2007 by Dr. Rosenbaum and others that says that cerebral palsy describes a group of permanent disorders of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. And I read that whole definition verbatim because I think it's so critical moving forward when thinking about cerebral palsy diagnosis to think about the information that clinicians have when they're making that diagnosis. And I also want to point out really critically in this consensus statement from 2007 that it was explicitly said that CP is not an etiologic diagnosis, but a clinical descriptive term. And pretty much what that means is that you can diagnose cerebral palsy regardless of what caused it. You look at the person in front of you, you assess whether they have a non-progressive motor disability. And if they do, regardless of why they have a non-progressive motor disability, they have cerebral palsy. So even though that can seem pretty clear cut, obviously a lot of people can fall under that diagnostic umbrella. And it seems clear that the cause shouldn't matter. There are several reasons why there might be cerebral palsy diagnostic variability, meaning different people might diagnose it differently. One of those reasons is, as you may have heard in one of the webinars earlier in the series, the genetic contribution to cerebral palsy is being increasingly recognized. And it's unclear how clinicians are integrating this knowledge with the established definitions of cerebral palsy. Second, some of these definitions show a discrepancy with regards to whether or not people with diffusely low tone, so I'm not talking about people that have spasticity or people that have dystonia, I'm talking about people that have low tone, not high tone. There is a discrepancy with regards to whether or not people with diffusely low tone can be diagnosed with cerebral palsy or not. And some registries, the European cerebral palsy registries, for example, explicitly exclude people that have diffuse low tone, so whole body low tone, in their cerebral palsy registries, while other registries include people with diffuse low tone. So because of that, looking at the person you see in your clinic, a clinician may have trouble figuring out if a person with diffusely low tone has cerebral palsy or not. And then lastly, there are multiple different types of clinicians involved in caring for people with cerebral palsy and in diagnosing cerebral palsy. So what we wanted to ask first, before I get into talking about family and community views on cerebral palsy, is how physicians are diagnosing cerebral palsy. So for this background survey, we surveyed almost 700 physicians who were members of the AACPDM, American Academy of Cerebral Palsy and Developmental Medicine, and the Child Neurology Society. These were physicians that exclusively practiced in the US and Canada. And of the 700 physicians that we reached out to, we got just under a 50% responder rate, so 330 respondents. And you can see that we got quite a mix of different physicians. I'm not going to get into the subspecialties here. You see that because we surveyed the Child Neurology Society, in addition to AACPDM, we have somewhat of an overrepresentation of neurologists. But all of these physicians were surveyed because they had a specific interest in caring for people with cerebral palsy. So we really felt like these people were the self-declared experts in diagnosing cerebral palsy because they specifically said they had an interest in that field. So when we looked at whether diagnostic variability existed, what we did was we gave these physicians hypothetical patient scenarios where we described people that had a genetic cause of their cerebral palsy, a form of motor disability that involved diffusely low tone, or both. And we saw that 40% of the physicians that we surveyed said they would not diagnose cerebral palsy if it had a genetic cause. And 12% of physicians we surveyed said they would not diagnose cerebral palsy if it were associated with diffuse low tone. And then of the physician specialties that we surveyed, neurologists were 5 times more likely to diagnose cerebral palsy in a person with diffusely low tone compared to any of the other specialties. And that's at least 5 times more likely. So it was 5 times to up to, I think, 12 times more likely, depending on the specialty. So even though we know that cerebral palsy can be diagnosed regardless of the cause, this survey data showed us that cerebral palsy can be diagnosed differently based on the cause and the doctor that you end up going to see. All of this data, as just a brief plug, will be coming out in Pediatrics in February. And we feel pretty strongly that this information is should be practice changing to make sure that the physicians that care for people with CP and are diagnosing CP are doing it in a consistent way. And if this is the overall conclusion of our study, we wanted to know how this is affecting the community. And I wanted to do that by focusing on the cause. So if really cerebral palsy diagnosis differs in the eyes of the physician based on the cause, regardless of what the consensus definitions say, what do families feel about that? What do people with CP feel about that? So we asked caregivers and people with CP about their views specifically regarding what a CP diagnosis means to them and what an etiologic diagnosis means to them, meaning diagnosis of the cause of their CP. So we surveyed people through CPRN with the gracious assistance of Paul, and we have currently 153 respondents. We also surveyed people through another organization called the Simon Searchlight Group. And this is a group that primarily works with children with autism, but also has a subset of that group that have defined genetic diagnoses and also have defined diagnoses of cerebral palsy. So we wanted to know in this group of people that we know had definite genetic diagnoses or suspected genetic diagnoses, how their views on cerebral palsy diagnosis may differ from the views of the respondents in CPRN, who may or may not have a genetic diagnosis associated with their CP. Another key difference between these groups is that the vast majority of people that we surveyed through CPRN were adults with CP, and that's people over the age of 18. And all of the people we surveyed through Simon Searchlight were caregivers of children with CP. So another demographic look of the respondents that were surveyed through CPRN, this is a breakdown, a very rough breakdown of functional abilities based on functional classification system levels. And level 1 is generally associated at the left of these graphs, generally associated with having greater functional ability in different modalities. And level 5 is generally associated with having less functional ability. So you can see that the CPRN respondents tended to segregate towards level 1, so having greater functional ability across multiple domains. So this is gross motor, fine motor, communication, eating and drinking, and visual. And you can see that the Simon Searchlight group tended to have more of a spread across functional abilities. We asked people what other diagnoses they had other than cerebral palsy. And there are a couple of interesting things I want to point out here. And some of this is based on, has some selection bias associated with it. So in terms of genetic diagnoses, you see that the vast majority of people in the Simon Searchlight group said that they had a genetic diagnosis. And of course, this is by design. People in that group either have a confirmed genetic diagnosis or are suspected to have a genetic diagnosis. Interestingly, and this is still preliminary analysis, none of the people that we surveyed through CPRN said they had a genetic diagnosis associated with their cerebral palsy. Which I find fascinating, particularly because we know in the literature, and some of this is really fresh literature from some of our CPRN investigators, that somewhere between 14 to 30% of people with cerebral palsy have genetic factors that contribute to the cause of their CP. So that likely means that there are a lot of CPRN respondents out there that have genetic diagnoses and don't know it. Interestingly, there was quite a large proportion of CPRN respondents, 40%, that had no other diagnoses other than CP, which is also interesting given the high rates of other symptoms associated with CP, like ADHD and autism and epilepsy, and the fact that these people also did not have a causal diagnosis. So they did not have a diagnosis explaining why they had CP. So there's a lot of opportunity to look into what are the other associated symptoms that people with CP might have who are responding to the survey, and what are the causes of their CP, and could any of them be genetic? We also wanted to ask who is diagnosing CP. And if you remember, I showed you that there are quite a few different specialties involved in caring for people with CP and diagnosing CP. The Simon Searchlight group, predominantly the group got their CP diagnosis from a child neurologist. And again, this does belie some bias. So if I go back to the last slide, you see that these children in the Simon Searchlight group had high rates of autism and high rates of epilepsy. But I would point out that it's hard to know what the chicken and the egg is here. So did these children get diagnosed with autism because they ended up seeing a child neurologist, or did they go see a child neurologist because they had a suspected autism diagnosis, or was it the CP diagnosis that brought them to a child neurologist? This is particularly interesting to me because the Simon Searchlight group is also the group that has tended to have a more thorough genetic diagnostic evaluation. And I bring up all of these points with full disclosure that I'm biased as a child neurologist, and also noting that we recently published this paper about the role of child neurologists and neurodevelopmentalists in diagnosing cerebral palsy, and how people with specific skills, like child neurologists in motor phenotyping, meaning understanding what cerebral palsy can look like, and in diagnostic evaluation of cerebral palsy, which includes child neurologists in addition to other subspecialists, we really feel like these people are the ones that should be diagnosing CP and engaging in the diagnostic evaluation. So now to kind of the meat of the matter. So what are the views on the cause of CP? So what did the CPRN respondents and the Simon Searchlight respondents say about the causes of their CP? So first we asked, has the cause been discussed with you by a clinician? And the vast majority of Simon Searchlight respondents said that yes, the cause had been discussed with them. Fewer said that the cause had been discussed with them in the CPRN respondent group. And I again want to point out that 38% of the CPRN respondent group know what has caused their CP. To me, this is a shockingly surprising finding, because when I think about how I evaluate patients I see in my clinic, your diagnosis of CP is coupled with what we think caused the CP. And I think that's important because it helps us guide the diagnostic evaluation. Do you need genetic testing for this patient to see, to help with family planning, to help with prognosis with regards to whether their symptoms may be associated with this child's CP. And it also helps with regards to, at least in my experience, giving the family an understanding of why their child has CP, or giving the person an understanding of why they have CP. And particularly for a lot of the parents in my clinic, that can provide a lot of I guess closure might be the word that I'm trying to get at. It's just really nice for a lot of families to know, and a lot of people to know about their own CP diagnosis, what caused it. So it was shocking to me to know that only 38% of people, of the CPRN respondents, knew what caused their CP. And I'll be interested to hear what the people listening in to this talk think about that. Then we asked people whether we thought it was valuable to know the cause. And I want to contrast the CPRN respondents that know the cause of their CP, which is 38%, with the CPRN respondents that think it's valuable to know the cause of their CP, and that's almost 80%. So again, this highlights the need for us to really engage in a thorough diagnostic evaluation for people with CP, and perhaps educate clinicians on the value of doing this, not just for medical reasons, but in terms of how families and people with CP see that value to themselves. So the last bit of data that I'm going to focus on is the intersection between having a CP diagnosis and a genetic diagnosis. Meaning, would people prefer to have only a CP diagnosis, only a genetic diagnosis, both diagnoses, either one, both, doesn't matter to them, or that they weren't really sure? And the responses were quite a bit more varied for the CPRN respondent group compared to the Simon Searchlight group. Keeping in mind that the Simon Searchlight group is a group that tended to have a genetic diagnosis, while the CPRN group, very few, if any at all, had a genetic diagnosis. When we look at caregivers of people that have both CP and a genetic diagnosis, the majority of those people find value in having both diagnoses. When we look at the CPRN respondent group, many of whom don't know the cause of their CP, the responses tend to vary much more, including a higher rate of I don't know and any, meaning suggesting to me at least that the value of knowing the cause of CP, though it seemed inherently valuable, the tangible value still remained unclear.
Hi.
Oh, sorry, is someone trying to ask a question? Maybe
yeah,
not.
it's Sue. Can you hear me, Susan Paserno?
Yes, I can barely hear you. Sorry, if you could just speak up a little bit.
Sorry. Let me try my headset. Hold on a second.
Sorry, Susan, if you wanted to just enter what you wanted to say in the chat, that could be helpful too. I'm also happy to, we'll figure it out. Once we figure out the sound.
Now it's on, I think. Now it's on if you can hear me.
Oh, yes. Yep, I can hear you now.
Sorry about that battery issue. Okay, so I think if we could go back to the last slide, I think there's a couple different things going on here when I look at that.
Susan, can I ask you a question before you go on with your question? Buma, if you're like, I would love to hold the Q&A till the end. We didn't say anything about that in the beginning, but
okay.
I am, if you're okay with that, Susan, can you hold your question and we can come back to this slide if that's what your question's related to?
Sure, I guess.
If you don't feel like you'll understand going forward, I like clarifying questions fine, but if you know, there's, anyway,
well,
so if you,
I'm not understanding what that particular slide means in the sense that it could have two different meanings.
So go ahead, ask. That's
Okay.
a clarifying question. That makes sense. So go ahead.
Thank you. With this last slide, I was kind of hearing you say two things. One, that if people had a CP diagnosis and a genetic diagnosis, they would want to know it because it exists, which I think most people who reach a level of maturity, if they have something wrong with them, they want to know about it so that it can be treated or that they can work on accepting it or whatever. But I don't think people are saying that they want to have CP and a genetic diagnosis, or that they necessarily think they have both, right? It's
Correct.
just that they're saying if they had both diagnoses, they'd want to know that they had both diagnoses.
That's absolutely correct. Yes.
Okay, thank you. Go ahead.
No problem. So in actually following up, Susan, on that question, here is an example of a quote from one of the CPRN respondents about what the reasons that they think having both diagnoses made sense for them. And I'm just going to read this. We like having the genetic diagnosis because it connects us to a small group of caregivers who also have children with the same rare genetic diagnosis. I also very much appreciated having the cerebral palsy diagnosis, as it was the reason our daughter immediately qualified for physical and occupational therapies as a baby. And I'm sorry, I think I said this was a CPRN respondent quote, but I think this is a Simon Searchlight quote. I think it's interesting thinking about, Susan brings up, you know, more information is better. If there's something associated with what's causing your CP, it's valuable to know just in the interest of having information. But this speaks to kind of the practical benefits of having both diagnoses. So to summarize what I've talked about, there's variability in how CP is diagnosed currently, which is something we need to address as a field. The minority of CPRN respondents know the cause of their CP, but the majority of CPRN respondents want to know the cause of their CP. So this is also something that we should be addressing as a field. Genetic diagnoses among CPRN respondents that the respondents know about are rare, even though we know the genetic contributions to CP are relatively common. So again, highlighting another a gap that we need to address. And this is specifically with regards to the last slide that we just discussed. Families of children that have both CP and a genetic diagnosis largely prefer having both diagnoses. But when we look at the CPRN respondent cohort at people who tended to predominantly have a CP diagnosis and not necessarily a cause diagnosis, the responses were more mixed. So with regards to how to address this, I've already talked about the onus that we need to put on ourselves as a field in terms of educating ourselves with regards to what the community wants in terms of knowing the cause of their CP. And also with regards to the preliminary data that I described to you about the variability in CP diagnosis, we also need to clarify, shockingly, what CP is with regards to how it's diagnosed amongst different practitioners. So I find these results surprising and really highlighting opportunities for improvement for all of us, caring for people with CP and diagnosing people with CP. So my Twitter handle is here. Feel free to reach out to me there. I want to acknowledge all of the people on this slide, but particularly Paul, Michelle, Jennifer, Darcy, and Michael, who were key contributors to the data that I presented today. And Paul and Michelle in particular helped extensively develop the survey that was sent out to Simon Searchlight and CPRN. So special thanks to them for that. And with that, I'll take questions.
Great. Well, thank you so much, Bhooma. That was great. I've been wanting to ask a question since one of the earlier slides, so I'm going to ask that, and then I'll say to everyone, what I think will work best is if you enter that you either want to ask a question, if you want to ask it live, or enter your question in the chat, and then I'll call on people in order that was raised, and then I'm going to use the power of being the host, ask my question first. So given that there were 44 parent caregiver responses out of CPRN, did you do any comparison? Because I got to believe CPRN, MyCP, because the first study we launched was about adults, currently is just a little weighted towards adults. And so I'm not surprised that there's less known there. Did you do any comparisons where either for physical, for across the physical functioning, or looking at any of the attitudes where you looked at just the parent subset for CPRN and compare it to Simon Searchlight, or not yet?
Yeah, that was actually the plan for today, but I didn't get to it, but I will.
Okay.
I think it'll be really interesting to separate out that group and compare that group, which has more similarities to the Simon Searchlight group also, because they're caregivers of children with CP, and see how that segregates out with comparing to adults with CP and whether those responses were different. I absolutely agree with you.
Okay, great. Okay, so there's a statement but not a question in the chat. If anybody has a question, go ahead, Susan. If you want to ask your question, just unmute and fire away.
Hi. I wanted to mention, I thought you might find this interesting. I was never offered any ability to find out what my cause of my CP was. No doctor ever suggested I try to find out or whatever. And at the age of 45, I had a bout of benign vertigo, and they were doing an MRI, and it just hit me as I was filling out the paperwork. I said to the tech, can they see the cause of my CP while they're looking for the cause of my vertigo? And he said, yes, but he's not going to tell you unless he's been asked to look. And I started shaking, and I wrote on the form, for the love of God, I'm 45 years old. I don't know what the cause of my CP is. Please, radiologist, read this and tell me. And I I handed it to the people, and I got back the report, and it said benign vertigo. And by the way, I happened to notice a PVL while I was looking for the cause of the vertigo. That's how I found out, and I think that often is the way most people who are adults find out, who didn't have it offered to them as children. So it's concerning. But also, I understand, and I know that people have seen me post on the chat board about the genetic research that's going forward. I realize there's a purpose to it, but I'm also a little confused because just the other day, we have several support groups on Facebook for people with CP, and this young adult wrote in and said, I saw a family that had 2 people with CP in it, and I was wondering if that was common. And can the adults on this support group, can you weigh in? And I weighed in and I said, well, I'm 58 and I've known, probably 100 families with CP, and I can't think of one. And then all these other people weighed in too, and they said they'd never met a family with 2 people of any relationship with 2 members with cerebral palsy. So on one hand, I see the importance. If there's a genetic component there, we need to identify it and maybe research it. But on the other hand, in the real world, I'm 58 years old, and I can't think of one family I've met in my life that has 2 family members with cerebral palsy. So I'm confused.
Yeah, you're wondering what the practical application is of all of this genetic stuff
Yeah.
that we're talking about.
Yeah.
Yeah, that's a great point. First to your first statement, that I guess surprise diagnosis is sadly how a lot of people find out what's caused their CP, particularly as adults. And that's something else that there's a group within CPRN working on that I'm collaborating with, talking about how do we educate, because I'm in neurology, how do we educate adult neurologists about the things that you need to look for, including evaluating someone for the cause of their CP when an adult with CP comes to your clinic. So thank you for that story. And again, that's a huge opportunity for education of clinicians that we need to fill. To your second point, I think when people think genetic, they automatically think inherited, which can be true. But there are a lot of genetic causes of CP that aren't necessarily going to be present in multiple people in the family. It could be a brand new mutation that shows up in the person with CP that isn't inherited from the mother or the father. And in that case, and that happens actually quite frequently. So one of the latest papers published by Michael Kruer and Peter Jin that I referenced earlier in the talk show that there was a high burden of what's called de novo or brand new mutations that are associated with cerebral palsy. And I guess then the question is, well, who cares about, why do we care about those mutations? And the reason is, if you can identify those mutations in people as being a cause of cerebral palsy, and you can get those groups of people together that have comparable mutations, comparable presentations of their motor symptoms, you can see what are the symptoms that a person with this set of mutations and this set of symptoms has that you might expect someone else with the same set of mutations to also have. What are the treatments that worked for one person that might work for another person? And when you're talking about cerebral palsy, which is just so broad, it's very hard to figure out what treatments are going to work for people, because a treatment that works for one person with CP doesn't work for everybody with CP. But if you start thinking about groups of people that are similar, and in one way you can think about it is genetically, then you can think, okay, well, if a treatment worked in this one person with this genetic cause, maybe someone with a comparable genetic cause will have a comparable response to that treatment. So by figuring out the cause, the specific causes of CP, we get closer to coming up with targeted treatments for CP. Does that make sense?
That's very helpful. Thank you. Thank
You're
you.
welcome.
And in fact, Buma, I don't know if you were on the call with Michael where he talked about this in the most recent investigator meeting, but he talked about a specific example of a finding that was clinically relevant. I think it was about diet and about whether or not ketogenic diet worked or was actually potentially risky for a certain genetic mutation. Were you on for that, or are you aware
I
of
wasn't
that?
on for that investigator meeting, but I know that, I mean, there are other talks he's given, I know, where he's talked about ketogenic diet and using L-DOPA specifically targeted towards the genetic mutation associated with cerebral palsy. And there are a wide variety of genetic mutations that can look like cerebral palsy where ketogenic diet can help or hurt. So
Right.
it is really valuable to know which of those mutations someone has.
Right. In fact, can I just ask, will you, I'm going to stop your participant sharing
yep.
so we have a bigger screen. Yeah, that's okay.
Yep.
I just want to make it so we had for the recording benefit, we've got bigger, headshots. So I have a question for you that is related to something someone asked, which is, the survey is still open, although right now it's closed to adults because we have we've accrued enough in that arm or in that cohort. But if someone here listened to this presentation, do you feel like that would skew them? Like you wouldn't want them to go and take the survey now because of like it's a biasing? Yeah.
Yeah,
Okay.
probably.
So I can keep an eye on who listen if you get new ones. But so that I should have made an emphasis to people. And oh, by the way, take the survey before you hear the results. But,
That's, I mean, but if you do have, it's interesting. I'm seeing this comment. I know this is way too late, but I would actually change my survey response from if there was a genetic cause to my CP. I initially said no, but it was important for me to know before I had children 27 years ago. And I mean, that's really valuable for me to hear. It's valuable for me to hear that educating people on this topic can make them learn new things about what is valuable to them about their CP diagnosis and about a potential genetic diagnosis. So I would say still, if you're interested in reaching out to me and sharing that information, feel free, but don't take the survey formally if you heard this talk.
yeah. And there's a question from Danielle. Danielle, if you want to unmute, you can ask your question.
Hi,
Yes.
Danielle.
Hi.
How are you? Danielle and I know each other well.
So here's a question for you, Dr. Buma. In kids who already have a etiology or have a reason for their CP, like HIE or stroke, what do you think it's still worth continuing to explore a genetic diagnosis?
Oh, I love that question. Yes, and I think that I would say currently in the current genetic testing climate, I would say yes sometimes. So we both know that there are kids that have cerebral palsy due to, let's say, a bleed that they sustained while mom was still pregnant with the baby. And sometimes, often those bleeds are rare. It's unusual for babies to have a bleed in utero. And people just say, oh, they had CP because they had a bleed, but nobody thinks about why did they have the bleed. I'm thinking of another set of patients that had brain bleeds very late in their NICU course, which is really very unusual. Usually when you see brain bleeds in babies that are born premature, it happens very early in the NICU course. So if you think about what causes someone's CP, yes, it may have been a brain bleed, or yes, it may be something that looks like PVL on MRI. But if the clinical story is still odd, if it doesn't fit with the mechanism of injury, then that person, I think, should still undergo genetic testing to see why that injury may have happened.
Yeah, I think that's really useful and important. And I guess maybe outside of the scope of this talk, but the next question would be, how far do you go? How far do you go? there are different levels of genetic tests. Is it worth sending like an initial kind of screening test, or going for the full shebang, big expensive test?
Yeah.
I don't know.
So some of this is, I think, restricted by, unfortunately, insurance approval as well, at least in Missouri. So we have to, a lot of the time, send a CMA, so a more limited, that's not fair to say about a CMA, but a different kind of genetic test
Right.
before you set a broader genetic test, like a whole exome sequencing test. I think the more...
maybe a question that might be useful to add to the research that's ongoing is, of the kids who go on to get genetic testing, how many get a genetic diagnosis from the initial screening genetic testing versus how many additional kids get a new diagnosis from testing beyond that, like a exome or a genome?
That's a great question. I think I'm going to share a paper with you. So Sid Jane has worked on that for neurodevelopmental disabilities, not specifically CP, I think more focused on autism, to be honest with you. And they've shown that whole exome should replace the CMA in terms of first line testing, which is totally against the guidelines that we have. But,
And to add to that, so Dr. Kruer's study is whole exome, is it not?
Yeah, so Dr. Kruer's study is whole exome. I think the question that Danielle's asking is it still worth sending a different kind of genetic test first that may be cheaper, that's not a word, cheaper and easier to access, and then sending whole exome if that's negative, or is the yield with whole exome a more a broader genetic test, does that justify sending it first? And I think in the next 5 years, hopefully, we'll see that people are starting to shift to sending whole exome first, which is not what the current guidelines for neurologists at least say.
And I would add, if people haven't watched Dr. Kruer's webinar that was from back in July, I would recommend people do that, because that study is actually launching imminently, and we're going to do a whole exome sequence on 500 trios. So the both birth parents have to be alive and willing to participate in the study in addition to the child. And originally it was going to be only conducted in kids that had an unknown cause of cerebral palsy, and it's actually going to be done openly, in which case we may get answers to these questions of kids that had bleeds, but also, like that there may be some propensity based on genes to end up with CP. So, anyway, so I want to turn to Amber Gorman, who was next up with a question.
Yeah, I wanted to know what percentage at this point in time is that is genetic versus, like, my understanding is that it's always been known that there's been a small genetic component for CP, or speculated that there was, but is that becoming more like there's a greater percentage now than what was known before?
Right.
I just wanted clarification on that.
Yeah, so that our knowledge of genetic contributors to CP has evolved quite a bit. So I think the last big review on this coming out of the American Academy of Neurology said something like less than 5% or less than 3% of kids with cerebral palsy have a genetic contribution. And now when we look at the studies that have been published in aggregate, some estimates say that up to 30% of people with cerebral palsy have some sort of genetic contribution. And that's not to say that the only cause of their CP is a gene. That's to say that there are many genetic risk factors, and this person with cerebral palsy very likely had a genetic contributor, a genetic risk factor to why they developed CP.
So does that include, like, the most obvious causes, like prematurity in addition to a genetic factor?
Yeah, so yes, in some cases, because if you think about kids that are born premature, not all of them develop CP. there are some kids that are born at 24 weeks and maybe they have some ADHD or some mild cognitive issues when they're young, but they never develop CP. And there are other kids that are born at 24 weeks that end up getting CP with quite a bit of functional limitation. And then there's this whole continuum in between. And some of that could just be due to chance and luck. But a lot of that could be due to genetic variation that we're just now starting to sink our teeth into. And I think figuring that out for CP is going to be critical.
Okay. And how do you weed out like birth trauma, like those other factors that also go into that whole, that could also be part of it?
Yeah, so I think, are you saying how do you differentiate between, if someone has birth trauma, how do you know that it's not just the birth trauma that's caused their CP? How do you know that it's something else?
Right, versus like being, like how do you single it out? Like if there's birth trauma, prematurity, and a genetic component, how would you weed those out and be able to know that? Or even transgenerational trauma,
Right, yeah. So I guess I would answer that from a practical clinician standpoint. I think if I'm seeing a patient and I think they have multiple different causes of their CP and each of those confer different risks and different treatment options, then it doesn't matter to me, and I don't think it matters to my patient which one is the top of the three causes or which one is the 99% cause and if the other two are the 1% cause, because if they contribute something to my understanding of the things that can help me treat this patient, I think that's the most important thing. But I guess what I would say is it's going to be, from a broader standpoint, I think it's very rare, or it will be very rare, that any of us will say maybe 5 or 10 years from now that there is only one cause to this person's CP, that the only thing that did it was that they were born at 24 weeks and there were no other risks from anything else. I think for most people, we'll say, here are the risk factors for their CP. They were born premature. It looks like they developed PVL. It looks like they developed severe PVL because of this genetic risk factor. And all of these factors taken together give us a full comprehensive understanding of why this person has CP and guides their treatment.
Okay, thank you.
Sure.
So Buma, there's one last question and then we're going to wrap up.
Okay.
Susan asked, I saw one research study that claimed Alzheimer's and CP were related. Does the current research show this? Oh
gosh, that is a huge controversy. So there have been various reports that have very variably linked the ApoE4 Alzheimer's disease causing allele with CP. Some reports link the allele, the pathologic allele, meaning the Alzheimer's disease allele with CP. Some people link the normal or the non-disease causing allele with CP. So we don't really know. I think the initial study was, I think it really shook up the field, but it's been hard to confirm, or it has not been confirmed definitively with follow-up studies. With that said, we know very little about what happens with regards to dementia or cognitive outcomes in people with CP as they age. And again, this is something that we as neurologists need to advocate for, because we tend to be the people that diagnose people with Alzheimer's disease and characterize cognitive ability and dementia with people as they age. And I've got to tell you that not a lot of adult neurologists are looking at adults with CP and thinking about what the rates of dementia and Alzheimer's disease are in that population and if they're different. There's a small, I shouldn't say small study, there's a large study that was just published as an abstract only. I haven't seen it come out in print, that suggests that people with CP do have a higher risk of dementia if they also have epilepsy or also have intellectual disability. But that's just one study, and it's not officially out in the literature yet. So I guess short answer is we don't know. So I'll leave it there.
Okay, well, Dr. Buma, I am going to say on behalf of the community and CPRN, thank you so much for your time tonight, your passionate about so many of these issues. It's really great to have you, at this point in your career, so passionate about all this, and I think it's going to make for great things. So first of all, thank you very much for your information tonight, and come back and do another one when we finish all the recruitment for the study and we have an update. That'll be great to do sometime maybe in 2021. So thank you very much. Everyone, don't forget about the fact that on December 7th, I think it is, Dr. Ed Hurwitz is going to talk about body composition and how that can be used as a sort of a predictor for outcomes for cerebral palsy in adults, well, also in peds. So that's going to be a fascinating new study that he's gotten some preliminary funding for. So anyway, thank you all. Thank you, Buma.
Thank
and
you.
I'll post this tomorrow. Bye.
Bye.